Hello and welcome to the latest in our series of NR Times webinars, roundtable discussions, and today we're focusing on achieving person-centred care in Huntington's. So today we're really going to focus on creating a picture of excellence when it comes to patient-centred care. And we'll be trying to cover and dig out insights that could benefit care providers and, of course, individuals living with the condition. So we've got a group of experts with us today, diverse and distinguished backgrounds and experience, who've agreed to share with us their understanding, their thoughts and their insight. So I'm going to ask our panellists just to say a few words of introduction about themselves, their organisations and their areas of particular interest. So just in order that, in the order that I can see everybody, if you don't mind, I'll start with you, Vincent.
Hi everyone, thanks Alistair and thanks for inviting me today. I'm Vincent Harding, I'm a clinical and forensic psychologist at St Andrew's Healthcare Northampton. We're a large charity, a not-for-profit charity with sites in Northampton, Birmingham and Essex, and opened back in 1838. So we support people with a range of diagnoses and needs, including those with Huntington's disease, both male and female adults. I've worked with people with HD for about 10 years now, starting as a healthcare assistant.
Great, thanks very much, Vincent. Heidi.
Yeah, so I'm a care centre director of a small nursing home. We've got 41 beds, currently looking after 29 residents with Huntington's disease. I've been here for 16 years, started off as a healthcare worker, then went to a nurse, then a ward manager, and worked myself up to care centre director. So just a little bit of knowledge along the way.
We're looking forward to hearing more about that experience, Heidi. Allan.
Morning, thank you, Alistair. Thank you for inviting me. So I'm Allan Perry. I'm a consultant neuropsychologist, and like others on the call, I started as hands-on care back in the early 90s and worked through starting in brain injury. I'm currently the director of clinical services for a company called PJ Care, which is a family-owned, family-run business which has been going for about 25 years. We have 183 beds spread across Milton Keynes and Peterborough. It's specialist neurological care, including dementias, other degenerative neurological conditions, including Huntington's disease, as well as we do rehabilitation, brain injury rehabilitation, stroke rehabilitation, FND treatment, and we've just opened an outpatient treatment service in Milton Keynes as well.
Great, thanks for that, Allan. And Kat.
Hi, I'm Kat Martin, and I'm interim head of services for Scottish Huntington's. I've been with the organisation as a staff member for about 18 months now, but been part of the organisation since prior to its inception in 1989. So I have a bit of a dual background of I have both a personal and professional connection with HD, and professionally have worked with people with Huntington's for just over 23 years now. My background started in working with children and young people impacted by Huntington's, and then has progressed to working across the world, looking at how we can improve care, how we can improve clinical connections as well, and looking at the links and the liaisons between research, industry, and actual clinical care for people with Huntington's, and where at the centre of that are the actual clients and their families, because they need to be centre to all of this working together to improve things. And bringing in personal experiences as well as professional learning to look at how we develop services in Scotland, and ensuring that families get the services they need when they need it in an economy that's not really forthcoming for that kind of work being able to happen. So yeah, that's us.
Great, thanks, Kat. And Dan, we're just doing introductions, a little bit about yourself, your organisation and your areas of interest.
Yeah, good morning, thank you. And sorry, I'm a couple of minutes late, one of those mornings. Yeah, so my name's Dan. I am a physio by background, and and I'm 2 months into a new post as Director of Clinical Services at Circle Rehabilitation, which is a rehabilitation unit in Birmingham, treating anything from sort of acquired brain injury, multi-trauma, MSK, sports injuries. And yeah, so I say my background is physiotherapy, and some of the patients we will be treating will have HD. So yeah, my reason for coming on really is just to broaden my knowledge and awareness and see what's current best practice, etc. Really. So
Thanks very much, Dan. We're talking about excellence in person-centred care, so it'd be helpful to get a picture of what we think that means. Vincent, could we start with you? We'll go around the panel again, and could you say a little bit about what you think excellence looks like when it comes to person-centred care for those with Huntington's? And if you'd like to touch on maybe the challenges and some of the opportunities as well as part of that, and then we'll work our way around the panel. So, Vincent.
Okay, thanks, Alistair. So I think in terms of excellence in relation to person-centred care, it's about good joined-up care, early intervention, and proactive approaches rather than reactive. We need to start with the person and what's important to them, their background, their likes, their dislikes, their routines and preferences, and also their hopes and goals for the future. Because what we see is that people live for a long time with HD, and the important thing is about how we support somebody to live well with HD for a long time and to maximize and maintain functional skills and abilities. So for me, it really is about working in that co-produced way, using triangulation. So at St Andrews, we're the first non-NHS mental health provider to sign up to Triangle of Care accreditation.
I think Vincent has frozen there. Vincent, could you we just lost you for maybe about 15 seconds there.
Okay, I think there's a poor internet connection here, perhaps. I'm not sure where we got to. But I think excellence in terms of person-centred care is about joined up approaches, a focus on co-production, working with, doing with and not doing to or doing for, actively involving the person at every step of the way and learning from them. They're the person living with HD 24/7 after all, and they're the expert in terms of their experience. So we need to work with them, learn from them, and also bring their families and friends in terms of co-producing with them, where that's wanted by the family and the people in our care. In terms of challenges, briefly, I think communication can often be one of the big challenges. And again, it comes back to that idea of needing to be proactive rather than reactive. So I work with people at all stages of HD. I think in the early stages of HD, we perhaps have far more opportunity to start from the very beginning and think about what that person wants their life to look like and how, and to bring in advanced directive discussions, for instance, about what decisions that person would like to be made in the future. We are increasingly using technology. I think there's a long way to go on that front, but communication can often be one of the biggest challenges between professionals, but also by professionals with the people that we work with.
Great, thanks very much, Vincent. That gets our discussion off to a flying start. And Heidi, the same question to you. What does excellence look like? Challenges and also opportunities?
So it's always quite difficult, isn't it, as people start to talk, because you hear other people, you think, oh, that's the same sort of thing. I think it's always about remembering the person, remembering, I mean, our home, we have quite a lot that are very end stage, and then we might have a few that are mid stage. But it's remembering the person they were before and trying to remind staff about the fact that they had a job, what their jobs were, and getting that interest so that staff have something to talk about with them. I think that can be quite difficult at times, especially for those residents. We have quite some residents that come in that have no family, and we find that family history can be quite difficult, especially if they're non-verbal when they come to us, trying to find out that background information, what their interests are and things like that. So always that's a difficult one. Quality of life, I think, is a really big aspect trying to find things they like to do, taking them out in the environment. That also puts that awareness out there for people out in the environment about this condition as well. So taking them out just for the normal things that I would want to do. Let's go out and have a coffee and a piece of cake. I think that's really, really important for person-centered care, is to do the normal things that we would be doing. Go to the cinema, let's go to the pub and have a non-alcoholic lager, or play a game of pool. We've taken residents to the local pub and had a game of pool. Even if they can't hit the ball, it's about helping them to do it. So I think that's most of it. Challenges, I think our biggest challenge at this moment in time is getting funding. It seems to be really more difficult to get funding for residents to be able to be put into specialist care, I would say. That's our biggest challenge at the moment. Challenges for residents, I agree. Communication, I think, is the most frustrating, I would say, for a lot of our residents, not being able to communicate, or when they are able to communicate, but we find it really difficult to understand them. I think that's quite a frustrating time for them. And I think that's possibly quite often what leads to our behaviours, I would say, is around that communication. So we do have a great speech and language therapist at site who does help us with that. And we are introducing more and more assistive technology, as in we've got one recently where we're looking at things like simple things, how to turn the telly over, how to put the light on and off, and those sort of more simple tasks, I would say. But yeah, I think that's our biggest challenge at the moment, is funding and communication.
Thanks, Heidi. And as you say, apologies to Allan, Kat and Dan, because this does get a little harder as we work through the panel, and some of the chief issues have been mentioned, but I'm sure you'll add your own sort of flavour to that. So same question, Allan, to you.
Yeah, what they said. I think one of the biggest challenges is the fact that most of us work in very abnormal environments. I don't think any of us on the call live with 10, 15, 20 people, have 6, 8, 10 other staff around. So there's 40 people in an environment every day of your life. I think that's, so we're trying to do person-centered care in a completely unnatural environment. And I think that's one of the biggest challenges. And that's where we start, because just that environment alone, as we know, is instrumental in how someone feels, their behavioral stability, their emotional stability, their functional ability. Most people, if they've come from a home setting, they can't just walk into a kitchen at most of the places they're going to live and make themselves a cup of tea, because the risk assessment will say you can't, or there isn't a kitchen that you can go in, etc. So there's a whole raft of issues by setting up, 10, 15, 20, 25 bedded homes, as all of us have got, because that's what we do. And then hoping that people are going to adapt to a very unusual environment. So, the challenge for us at PJ Care has been to create environments. We're very lucky because all of the homes that we've built them. So they've evolved over the 25 years. The last one in Peterborough was built and finished in 2012. So, and that the units there, although they are that typical sort of 20, 25 bedded unit, they're vast on purpose. They're airy, they're light. The corridors are, I think, probably some of the biggest corridors you'll ever find anywhere in healthcare. So they've been built with space and light on purpose. And we have the ability to take people to a kitchen so they can do their own cooking. We tend to be risk aware rather than risk averse. One of our younger residents, because we've championed, PJ Care was set up as an early onset service. It was set up to try and support people that were going into nursing homes, so working age adults, to have a life which wasn't in a nursing home. So subsequently, we've had people in their late teens, early 20s with Huntington's disease, and in most decades of life. And we've had some of the younger ones in their 20s do a tandem skydive to raise money for the HD charity, for instance. You should have seen the risk assessment for that, which I was involved in. That was a few years ago. So that you can push the envelope, and I think, given the environments we have to work with, and what that brings in terms of, as I say, people's behavioural stability, the emotional, adjustment to suddenly living with 30, 40 other people milling around in a environment every day. I think if you can make it feel as boundaryless as possible for people, because we have fairly boundaryless choices in our lives. There are consequences to the choices we make, all of us on the call, but they can be boundaryless if we want them to be. We just suffer the consequences. And I think we have to allow everybody to kind of suffer the consequences within reason. We have a duty of care, but we have to allow that envelope to be pushed out as far as possible. Our residents go to main stadium football matches in central London. One of them's a mad Chelsea supporter. Her room is painted blue. She's got every Chelsea flag and football strip from every match she's been to. And those environments are pretty difficult to manage, but we make it happen. It's those sorts of approaches that are important. But we've also recognised as a company that actually these environments are not the best environments. Our goal is to build a village with houses. So you'd be living in maybe a 5-bed, sharing with 4 or 5 other people. And there might be people with HD, there might be people with other neurological difficulties, but people matched more to your life choices. If you lived a bohemian life, then you'd probably be living with other people with neurological problems with a bohemian lifestyle, coming out of the front door, having a back garden, coming out into a precinct, being able to walk into the laundrette and put your own stuff in the laundry, etc. So that's our vision for the future of supporting people with Huntington's and other neurological conditions, so that is it normal? Not really, because it's not their own front door, but it's as close as we can get it, I think, given that people have, there's lots of risks, behavioural instability. PJ Care specialises in managing, behaviour that challenges, as many people on the call will be expert in that too, with neuropsychiatry involved as well as neuropsychology. So, we know that it's hard for people to live, in the community, in their own homes, with the risks and challenges that and the community often, which isn't very sympathetic or tolerant. So I think there are other ways to do it in the future. There are other innovative environments that themselves become probably the best carer ever, and that's what we hope to create. And that's what Eaglewood, our Peterborough unit, it's the best. As I say, it's the best team member I've got. It's never late for work. It's never sick. It always shows up on time, and it always creates something quite magical for the residents. And I think there's evolution of that in all the services for people.
Great, thanks for introducing that ambitious tone to the discussion, Allan, and we'll come back and get really under the skin of innovation and new approaches. Kat, your thoughts on what excellence looks like when it comes to person-centred care, challenges, opportunities?
Yeah, I think I kind of really support all of the things that everybody's already said. I think one of the big things for us is the proactive nature of the work that we do. You've got to be ahead of everything, so you've got to have those discussions, whether that's about advanced directives, whether that's about power of attorneys, about guardianship, about planning. It's all got to be very proactive and done in a way that's really gentle, because what you're trying not to do is remind somebody that at some point in time they're going to be in an incapacitated state, that they can't make decisions for themselves. But you've also got to be proactive to prevent the crises happening as well. So you get to know these people over a long period of time, and you can see things that nobody would see as a trigger in them. And you kind of go, right, okay, we need to change, we need to intervene when there's nothing wrong. And I suppose the challenge that comes with that is that when you're doing community-based referrals out to speech and language, physio, OTs, they go, why are you getting me in here to assess somebody who's still walking, who's still talking, who's still swallowing, for a walking aid, for a wheelchair, for this? And we're going, well, because we know in 6 months they're going to need it, but the assessment takes 5 months, and then we're going to need. And what I don't want to get is that they're then stuck in a house where they can't do anything because we're waiting on a wheelchair, or we're waiting on a walking aid, or we're waiting on the fall happening before you'll do anything. We're in a kind of like situation just now where we're having to really manage expectations, but asking people to pretend they're iller than they are so that they can get the aids that they need just before they need them. It's difficult as well with generic speech and language services, OT services, physios, who are brilliant, but they're coming with an off-the-shelf solution to something that doesn't fit. So we're very much experiencing a square peg and round hole situation just now, and that comes with having to really try and balance finances all over the place, whether that's at local government, whether that's within the health board, whether that's within the social care sector as well. Similarly, what you said, Heidi, is the funding's not available, and what they're kind of going is, we can put someone with a really complex condition into a generic setting and it'll be fine, and then are really shocked and surprised when they kick off and they've destroyed a room, or that they're not settling, or that they're now refusing medication, or that they've gone downhill really quickly and they're losing weight because they're refusing to eat. Well, that's because you're serving them slop on a plate, because you've risk assessed them as a choking hazard. You've risk assessed them as a fall, so they're now in bed. You've risk assessed that they can't sit in the chair because you've not got a specialist chair and you can't afford the specialist chair. You're having to shower and change them multiple times a day because you've got generic continence products that, with someone with intense movements, mean that the continence is in their socks, their continence pads in their socks, and their clothes are soaking, the bed soaking, the chair. So all of this is, how do we get people with complex neurological conditions and put them in generic services, because they're half the price of a complex bed. And that's what we are having to battle with all the time just now, is that there isn't the funding, there isn't seen as the need for Huntington's to be kind of like a specific class, that they need this complex care package putting in, and that there needs to be a proactive element to it. And in the middle of this is a person, and that person has other people round about them, whether that's friends or families or people who love them, they're round about them. And everybody stops seeing the person and they start seeing the disease, and they start seeing the symptoms, and they start seeing the behaviours. And that just loses this person in there, which of course causes much more issues, and feeling that invisibility that we would all feel if somebody didn't see us as a single person and only seen, oh, I've got a real big movement in my limbs, or my trunk's really rigid, or a choke every time I drink something. That's all people are seeing and talking to them about. And the other bit that I think is understanding what's important to the person as well. So the amount of people with HD that I'll speak to, and you say to them, does your movements bother you? And they're going, no, it doesn't bother me. It bothers everybody round about them because I've belted them 3 times today when they've tried to help me. But it doesn't bother me. But what does bother me is that I'm losing my speech. And that's a really important bit of who I am. It's really important to my identity that I can still speak and I can still communicate, and nobody's helping me with that. So how do we do that? So it's about being able to kind of like be proactive about these things, and all the way through their journey kind of going, how can we make this better, and how do we still see you as that person, and being that bohemian person, or being that person who was interested in art, or being that person who was interested in hill walking, and similar to kind of like what somebody else had said about taking them out to do things, you know, like the tandem skydive, Allan, that you talked about. I've had people who have been near end stage Huntington's who wanted to go whitewater rafting, and we've made it happen. And I'll tell you, there is never a harder job than getting somebody with near end stage Huntington's into a wetsuit and back out it again. The rafting bit was dead easy. But you find solutions, really creative solutions, and spend weeks creating the risk assessment to make sure you can get it to happen. But at the end of the day, that person feels really seen, really heard, and isn't a burden on anybody, which is one of the big things that everybody that you speak to who has Huntington's or is at risk of Huntington's will tell you about. They'll say, I don't want to be a burden. I don't want to be a burden to anybody, so I'm not going to have relationships. I'm going to put myself into care. I'm going to take myself away from society. No. Back up. Let's look at how we can make this easier, how we can see you, because you've still got a lot to give. And it's not about your ability to communicate. It's not about your ability to sit still. It's not about your ability to eat something without choking. It's about you being you, and us still seeing you as a person. And I think that's what person-centred care has got to be. It's about seeing the person and not all of the problems that we need to solve round about it. As professionals, our job is to work with you to solve those problems and try and be creative and not try and fit you into a generic box, because with Huntington's, generic boxes don't work.
Yeah, I think that's a great point, Kat. And I think that this is where, going back to a point, Vincent and others have made the point about, advanced directive. This is where, the Mental Capacity Act is a tricky thing to navigate, as all of us on the call know. But I think this is where, those capacity assessments, because now we can be very specific, do you want to have fish and chips on a Friday, as you've always done all throughout your life, irrespective of the risk of you choking and possibly dying, let alone some aspiration, pneumonia? Do you still want to do that up to the point at which it could actually end your life? Do you want to have that in there as part of your care plan? Yes, please. Okay, let's put that in then. So, I think, Mental Capacity Act came about to stop that paternalistic, oversight from clinicians like me and others. So it's enabled us to go, okay, we can have with great specificity, clarity for an individual, either at the time that we're supporting them or way ahead of the need, as you say, when those things become a real issue, so that you can actually have it, down on paper, so that people can still be supported to take risks.
Yeah.
Because that's really important.
It's so important, because we don't live in a risk-free world. We don't come from a risk-free world, but we put people into environments where it's all about the risk. Yeah. And it's not the risk of harm to that person, it's the risk of legislation. It's the risk of...
It's the risk to us.
And it's, yes, absolutely.
Which is terrible.
And that takes all of that, kind of like, this is a person's life, and we need to put that back in there. And the kind of like, do you want a fish and chips? You're all right to change your mind on that as well. Those regular conversations, even when people are deemed as not having capacity, there are certain things that they can still choose, that they can still go to say. And I think where we have long-term relationships with people and their carers, we need to listen. We need to do much better at listening to. They've always said, I had a client recently who I've known them for about 20 years, and has said their whole life to us, this is the type of funeral I want. I want buried, and this is where I want buried. And now they're like, no, I want cremated. And it's a complete flip. And it's like, well, no, they've always said that, and they've now got capacity, so we're going with what? No. Let's find out. Let's do the digging. Where does this come from? Because again, somebody with Huntington's and they've got loads of perseverance, all I'm hearing is about this cremation. And it's really important to them now to have that conversation, even without that. So it's like, how do we involve the wider family? Because they've already prepared, they've got the prepaid funeral plan kind of thing. So what is it that's changed? But we need to be okay with, even when people don't have capacity, there are certain elements, especially with Huntington's, where they are not cognitively impaired to the degree that some decisions are not theirs. There are some things that they will think they're absolutely fine to do, but there are decisions that we need to still enable them and allow them to make for themselves. And support it.
Thanks, Kat. I'm quite keen we've not heard from Dan yet. So, Dan, your thoughts, what does excellence look like from your point of view?
Well,
opportunities.
The tricky fifth person to go here, I think, in many ways, actually. So, listening in, obviously, many people here are working very closely with multiple, high volumes of Huntington's patients, lots of experience work with them. I might be able to offer some insight for somebody who perhaps hasn't. So I have worked in acute trusts and, have treated patients at that point in their journey. We will have some patients here coming, for some period of rehab for three months or so. But actually, the one thing that probably jumps out to me is there's probably that lack of exposure and awareness from a clinician's perspective. You might see me as a rotational physio back in the past. I'll see that patient for a few days in their acute admission, perhaps when they've had an aspiration or when they've become acutely unwell. And my goals with that patient at the time are keeping their chest clear, getting them, keeping some maintenance of mobility and strength, and getting them ready for discharge. Not necessarily looking at, have they had that conversation about what their long-term plans are, preferences are. So it's almost like a disjointed care there, isn't there? Or somebody may have come from that environment where they've expressed those, preferences, but when they come to the acute setting, it kind of, that momentum or that, what's the word I'm looking for? Continuity of care is kind of lost potentially, isn't it? So is there a bit of a lack of awareness throughout the care system, I suppose, when patients are coming from one environment to another? Would be one thing that sort of jumps out as might be a challenge. But also, in terms of what best practice looks like to myself, I think is that blend, isn't it, between what is clinical research telling us and what does the patient want? What are their goals, their specific, requirements? We can tell you what the best practice research might say, but if it doesn't align with their goals, that they may not engage with that as part of their treatment plan, so to speak. So it's finding out what is going to get them motivated, get them engaged, so that you get as much engagement with the plan long term, I suppose. And if that looks like, I'm a walker, I'm a hiker, well, actually, can I make your sessions, very specific to that, and everything we focus on is going to be geared to that. Or actually, if there's a functional day-to-day task, I really want to do this in the kitchen, well, everything we can do should be focused towards your goals, maybe. That to me is what patient-centered care is. It's a blend between what's the clinical research tell us and how can we make that specific to that patient's goals, and acknowledge everything everyone else has said. Those goals can change, preferences can change over time. But for me, that's the one thing that sort of jumped out listening to everybody there is there's perhaps not that connected care. These patients are going to be having, interaction with services for multiple years, and actually you come into the acute trust and there's probably that awareness of the person and their preferences. It's kind of, I'm treating the acute issue now, but not looking at the wider picture of, this is John, he likes his fish and chips on Friday. That's really important, isn't it?
I think, Dan, that's really important thing to bring up is we do struggle with residents when they do go into hospital. The knowledge around in the hospitals we find is quite limited. And bearing in mind, I live in a little area, and most of our residents will go to the same acute hospital, and we send everything that we can, care plans, in-depth care plans, information on swallowing, information on their dietary requirements and things like that. But you still then get the phone call, what level of food do they need, what fluids are they on, are they able to walk? And I don't think they have that understanding of Huntington's in the NHS sometimes, because it's so rare and they don't see it as often as to get that knowledge, I suppose. And I have offered training locally to our local NHS, which doesn't get picked up. So I think that's a big area that could be improved for the whole holistic care of somebody with Huntington's, is that if they are going into the acute, they have that understanding of the needs and they're not frightened by them, because I think a lot of the time they're frightened. They see the movements as agitation, they see the movements as aggressive, and then they will sedate, and that's always not the best thing to do. And they will give them things like lorazepam and diazepam, and actually sometimes that can make it worse. So I think there is a bit of education thing needed.
And I've seen that firsthand. I'm thinking when I was on a junior rotation, an acutely unwell patient with HD who had aspirated, and they needed their airway clearing, but again, very difficult with somebody who is he's got these involuntary movements. So it's and I've seen that where the doctors took the decision to do that, and I think I can understand why they did it, but it's the humanity of that, isn't it? And if there's other ways around it, less invasive ways, less restrictive ways, then like you say, it's the knowledge, isn't it, of how to manage that. The one thing that I don't know whether or not in your experience, the things that sort of jump out to mind, like these type of patient passports, all about me type documents, is there ways that they can follow the patient into the trust? I presume that's, or through services. I presume that's something that's
standard.
Really
I would say most of us
that'd
probably
be standard
already do.
for us.
I was going to say
we
most of
send
us
those
would
in.
send something.
We also send a nurse in every day to visit. So one of our
we send
nurses,
carers.
everybody that goes in, we send a nurse in every day from there, wherever the area that they live, to look at the care and the care plans at the hospital. Because like you said, Heidi, the hospital, don't necessarily understand the nature and severity of the diagnosis, but also don't know the person. How can you expect the hospital to know the person? You're all there to do a job, which is hopefully to rectify the person's, sometimes save their life, literally. So and that takes precedent. We can come in and actually help you understand the person a bit and check and make sure that that your knowledge is is augmented a bit on a daily basis.
Just
We've moved into new approaches. Vincent, did you want to come in there?
Yes, please. Just to come back to a few things, really. So I suppose in terms of public awareness and knowledge of HD, as you've touched on already, it is really quite limited. And the HDA did a recent survey around understanding in healthcare professionals. And I think quite shockingly, really, they found 85% of the 150 people surveyed needed to educate a healthcare professional on what HD is. So despite lots of media campaigns and webinars that the HDA facilitate, it's really a long way to go. Equally, to come back to that conversation around personalisation, I think it was yourself, Kat, who suggested it's really beneficial, isn't it, when we get to know somebody over a long period of time, because we really see them as a person and what matters to them, and then think about how to support that. So that really is a priority. But equally, I think it can be really quite challenging. And that comes back to your point, Allan, about our environments and how they can either enable or perhaps detract from ability to do what we'd like to do consistently, because you've got such a diverse group of needs, abilities, and change in needs and risks over time. And again, Kat, you mentioned about risk and what bothers people with HD. And often we find that their career isn't necessarily the thing that concerns the person the most. It might be speech, for instance. So I think it's that ongoing challenge around how do we provide opportunities and protect the person? Because our natural instinct is to protect, but sometimes in doing that, we can de-skill the person and we can intervene too quickly, too often, and take opportunities away from the person. And I think that's really just exacerbated by the limited evidence base, particularly from my perspective in terms of psychology. So there was a BPS paper about 4 years ago now, and whilst the evidence base is improving, the paper doesn't really tell us that much. There's a very long way to go. So we have to be creative, flexible, innovative. That's exciting, but it's also sometimes really quite frustrating. We're having to turn that evidence-based practice on its head and try and see what works and what doesn't work.
Thanks, Vincent. I'd just like to go around the panel again. We've touched on innovation, but I'd like to hear from each of the panelists if there were one or two things that you think would make a fundamental difference to improving person-centred care in Huntington's. What would those things be? Keeping in mind that we'll have a big audience watching this. I hope some legislators, I hope some policymakers as well. So if you had a key message about a more positive future and those things that would make a big difference, what would they be? Sort of final thoughts in this discussion from all of the panelists. I'll do it in reverse order this time, starting with you, Dan, just to be fair to everybody.
I think I had some time to think about this. I think education is, I know it's probably the most obvious thing, but sometimes the hardest thing to get out there, isn't it, is education for whether or not it's the public or for health professionals, and understanding that, depending on what environment I'm working in, what are the key responsibilities for me with this patient during this period of their care. If that's, like I say, going back to acute trust, or if it's their initial diagnosis period, what are the key things we need to be doing at those stages for this cohort of patients to set them off on the right journey, or to realise when they've fallen off of that journey what they should have in place at this period of time. So whether or not education and perhaps understanding what the responsibilities of the health professionals are at that stage of the journey, at that point of care or that environment of care.
Great.
Appreciate that.
Thanks for that, Dan. Kat, your final thoughts, just one or two things that you think could make a big difference, briefly.
I think going back to the education thing that Dan had said, I think we need to kind of get it through to people that what works for one doesn't work for all, and might not work for anybody else. It only works for that person. So we need to, generic needs to be ditched. And again, I think if we were trying to do anything with people who have never seen Huntington's, whether that's in an acute setting, as the statement that Jimmy Pollard uses is hurry up and wait. it takes somebody with Huntington's probably 6 times longer to process and do the same thing that we do instinctively. So hurry up and wait, just take a breath. You are in a really busy setting, you are in a really crucial environment, but you need to wait because that person needs to catch up with them. So what works for one doesn't work for everybody. And hurry up and wait would be my 2 things that I would want people just to understand about Huntington's a little bit more.
Brilliant. That's great, Kat. Thanks. Allan, your final thoughts?
Yes, I think first one for me would be the nature of funding. Heidi's mentioned, difficulties with funding. Continuing healthcare funding is what we're expecting to get for supporting people with Huntington's disease. I think, we employ our physiotherapists, our speech therapists, our OTs, neuropsychologists like me, neuropsychiatry, because you need a highly specialised multidisciplinary team working with the nurses and carers who are delivering the support day to day for the whole thing to be effective. That's not cheap. And there has to be recognition that supporting people with Huntington's disease, there isn't a cheap option. You need highly specialist people to do it, including, even our chefs. Our chefs have championed dysphagia diets and are training other chefs in how to prepare dysphagia food, mold food, so that it looks exactly as it would look on the plate. So there's that side of it. This is an expensive service. And, the government has to recognise that you can't cut corners financially with this. You have to put money into it to support people. On the flip side of that, is there a way to somehow slow down the progression of Huntington's? And I was involved in some research a few years ago with the Open University where we looked at haptic technology. So this is wearable devices that you put on arms and legs to train cueing, cadence, so people's walking was more effective, and it worked, and we published the data. So there's also the need for, and there are Innovation UK and other funding bodies you can get funding from for these sorts of things, but there is a need for funding of innovative technology that could actually slow the progression of Huntington's down, because we found that we could actually improve someone's gait by using haptic technology. That's significant. Other research has shown that if you take people walking over sand and sand dunes, physiotherapists from some of the Welsh universities, you can improve people's gait and balance, reduce falls. So there's ways to actually reduce the cost or slow the cost increase down by giving people a better quality of life for longer. And I think that's, again, another area that funding needs to be put in place for.
Great. Thanks, Allan. Heidi, 1 or 2 things that you think will make a big and positive difference?
So I'd like a cure first. That's always my first go-to, is that a cure would be great, but that's not in the pipeline for a very long time, I wouldn't think. I think the funding again and the education is probably the biggest things. That education, and that's everyone. But funding is the biggest thing. We need to be looking at this, and I think the biggest challenge is that they do come into specialist care, so they may come into our service and then within 6 months or so, because we've got them settled and we know them well and we're treating them as we should be and we've got everything in place, it's then, oh well, they're settled, they don't need this complex care and they don't need this setting now, and then they try to move them on. So it's about explaining to them that if they didn't have the psychology, the speech and language, the physio, that things would be different. So I think it's about education, massive.
Thanks, Heidi. And Vincent, you get the final word.
Okay, so again, continued education both for the public and professionals to raise awareness and understanding of HD and to ultimately support people with HD better for the longer term. Continued investment in research and the evidence base to improve that further. And finally, technology, an increasing use of technology to really give people with HD a voice.
Thanks, Vincent. That's a really positive note on which to finish a discussion where we've covered so many areas, but it does feel as though we're just scratching the surface. And I think in our times, we'll want to come back and dig into some of the things that we've touched on in much more depth in future discussions. On behalf of NR Times, can I just thank a fantastic group of panelists for sharing their experience and insight so generously. I'd also like to thank everybody watching. Please share this as widely as possible, both on YouTube and by accessing it on the NR Times site. This discussion really does deserve to be seen by as many people as possible. So thanks for watching, and thanks once again to our panelists for what has been a great discussion about Huntington's. Thank you.
Thank you, Alistair. It's a pleasure.
Thanks.